Good afternoon. My name is Sonal Kanswarat. Thank you, Andrew, for the kind introduction. I am a pediatrician at the Children's Hospital, and I also lead the Children and Young People's Asthma Program for the region. I'm always in awe of the experience and I always learn more from here than I ever expect to tell you about. So thank you for listening, and I hope that the coffee has been good and keeps you up. I'm grateful to the organizers as well for giving me this opportunity to talk to you about children and young people. And there must be competing interests when you have a respiratory PLI, but thanks for the opportunity. And this is why it is. This is a study of around 500 children who enrolled into an asthma study when they were younger, and they followed them up with lung functions right into the 4th decade of life. Now, this is, so the top one is supposed to be the normal growth of lungs and then decline in lung function. And you can see in this cohort that only 25% of children achieved that. So what we do now, what we do with children really determines what happens to them later and creates more work rather than less. So children are really, really important, and it's important that we get this right. My talk today, I'm covering some disparate topics, and it's a hard act to follow after Debs and after Arti, but that's what I'm hoping to discuss there. We'll talk about what's happening in asthma. To an extent, that's been covered by my colleagues, so I'll not spend a lot of time on there. We'll talk about the new guidance for preschoolers. And I reflect standing here 9 years back, delivering the same PLI. I was sent at the last moment by one of my senior colleagues. And then I got some feedback saying, oh, you've told every GP in Sheffield that they can't diagnose asthma under 5. So I hope I can make amends today. We'll talk about SABA, MART, and AIR. We'll talk a little bit about diagnostics. I've got some exclamation marks against it, and I'll come to those. And then I'll talk to you a little bit about the program we're running in South Yorkshire to get the children and young people's asthma care as best as it can be. This is the national picture. Two things I'd like you to concentrate on. First of all, year after year, you can see those spikes in asthma admissions. And that is unchanged apart from the COVID year. So across all age ranges, right up to 25, there is an yearly spike of asthma admissions to hospital. Needless to say, in the hospital, we only see the tip of the iceberg. You probably deal with much more than that. The second thing I'd like you to look at is the deprivation index. You can see that the asthma admissions are concentrated in the children who are from the most deprived population. So the top 3 are the most deprived population, contributing to the highest number of asthma admissions. And something to be said also about the fact that if you are from an ethnic minority population, you are disproportionately likely to present with an asthma exacerbation to hospital. And when they get to the hospital, we like to think things go really well, but they don't. We only give the standard of care, steroids, within the first hour to half of the children. And when it comes to discharge, good practice is that we check their inhaler technique and give them a personalized asthma plan. How often does that happen? Less than half the time. And this is what is really worrying. I hope everybody in this room knows that smoking is bad. And we should ask about smoking. And we ask about smoking for children who are presenting with asthma attacks 20% of times. And how often do we do something about it? I've got colleagues from Smoke Free Sheffield here, 10% of the time. So huge amount of work to be done in terms of recognizing the triggers to asthma, recognizing the environmental influence. But as my colleagues have said, asthma mortality in the UK is unacceptable. It's unacceptably high, and it's a combination of factors. And again, the most deprived children are being disproportionately impacted. Okay, so that's my cue to move on to the next bit of my talk. And these are all nice birds. And I'd like to sort of talk a little bit about lumpers and splitters, and I'll explain that in a minute. So, you could lump individuals into broad groups. You're all primary care physicians, nurses, or you can then divide them up split them up into smaller groups. But sometimes actually talking to the broader group or considering the broader group is helpful. And that's been the tension in children under 5 with asthma. So I'm sure you recognize one of the patients here. This is the common sort of history, at least I get in the hospital, of children under 5 who present with asthma. Various variations of this. So who actually has asthma, and why does it matter? It matters because you want to treat them well. And why is it important? Wheeze is very common in children, and up to 1/3 of children would have wheezed by their 5th birthday. We more and more noticing that as the bronchiolitis comes down, and hopefully we'll have a vaccine this winter, and the cases will come down even further, there's a disproportionate increase in number of children presenting with wheezing in the preschool group, and as compared to lower respiratory tract infections. And the same enthusiasm about asthma plans is not transferred over to younger children either. So only 30% of them get an asthma plan. This is my tertiary head-on, and that says, not all children who are under 5 and wheeze have asthma. And we recognize that. We recognize that under 5, you could have wheezing for a lot of reasons. You could be born with tracheomalacia, which is floppy airway, and going back to medical school, if you've got intrathoracic obstruction, you will present with wheeze. You could have an allergy to house dust mite, and we know children who are allergic to house dust mite more likely to have asthma. And again, RSV, commonest cause of wheezing. So my splitter mind, my need to pick up the right patient mind says that there is within that group a lot of different patients. And the other thing really is about treatment. So it's very well that there are different patients, but how does it matter? And it matters because we want to treat them all the same. We want to give them likely treatment for this inflammation, isn't it? The inflammation which RT, which Debs has mentioned. But what we don't know is that do under 5s actually have that inflammation? We don't know that answer. We don't know that mechanistic answer at all. And hence there is a reluctance to use the term asthma, because asthma will mean inhaled steroids. And so this is just another part, side of the story. But if you look at it from this angle, you look at it, this is an unselected group of around 300 patients. And you can see that the top ones have been given flixitide or fluticasone, and their exacerbations have reduced. So even in an unselected group, there is a reduction in exacerbations if you use inhaled steroids. Having said that, when you stop them, they do drop down to the same level as placebo. But maybe inhaled steroids do work in a non-selected group, so maybe you can lump them together. There is a little bit of nuance to the argument, though. This is a study, not a very big study, I think 200 patients or so, trying to see what the best step 2 treatment is for children with asthma under 5. And what they found was there was a differential response to treatments, and most children responded to inhaled steroids if they had to respond. But up to a third of children did not show a differential response. Then the worst response was just with placebo. And when they looked at it in more detail, if you've got an atopic tendency, if you've got allergies, then it's likely that you will benefit from being on asthma treatments. So there's a little bit of a nuance to the argument. It's not as simple as splitting them or lumping them together. And this is what has scarred me for the last 9 years, because there is a lot of terminology, isn't it? It's episodic wheeze, multi-trigger wheeze, wheezy bronchitis, and we throw them out. I mean, my favorite last few years was preschool wheeze, and that's But having said that, these are the two which are important for you. This is the guidance now. You use only these two categories, viral wheeze and suspected asthma. Okay, so this is under fives, and this is the code for viral wheeze, and these are children who, as it says on the tin, wheeze only with viruses, and there is nothing else going on in between times, and the exacerbations are pretty mild. And the second one is suspected asthma. And these are children who are touching ED again and again or being admitted again and again. These are children who have interval symptoms or using a lot more of their SABA inhaler. There is something about track score, but it's hard to find a track score, so I think you can probably leave that out. But essentially, if they have been poorly enough to be touching hospital again and again, then you would code them as suspected asthma using this code. We did try hard to get preschool wheeze as a code, but we were told that we can't have it, and that's why this is how we lump them now. So preschool wheeze, suspected asthma and viral wheeze. And this is the algorithm they ask you to follow. I can share this later on, and we will, but I'll just try and go through this with you. Just trying to see if the pointer is working. It goes away. Okay. So essentially what they're saying is that anybody presenting with wheezing to primary care, if they didn't require admission, then please code them as viral wheeze. And if they don't have any further episodes, then you remove the code. Children who are presenting with mild to moderate symptoms and they get admitted, and at that time we go through discharge planning with them. Children who have severe or life-threatening symptoms, they get coded as suspect asthma straight away. And these are the pointers we discussed earlier: 3 or more admissions to hospital if they've ever been admitted to ICU, or there's if there's any other concerns, then you'd code them as suspected asthma. The important thing really here is that you review them annually, and when they're 5, either you pursue a diagnosis or you remove the code at that time. Hopefully that's fairly self-explanatory. So we are restricting the term suspected asthma for the more problematic wheezers where there isn't possibly an alternative diagnosis, so they can have all the benefits of having the diagnosis of asthma. They have their regular reviews. They can have they can be called for flu immunization or relevant immunizations if need be. Just to remember that within the lump there will be, within all this, there will be children who have another diagnosis, and that will come up if you see failure to thrive. That's the single biggest thing. If a child is not growing, the child is not well. That's what I've been told as a pediatrician, and that holds. If the symptoms present from birth, or whether there's other systems which start then getting involved, you notice a chest wall deformity, you notice some nasal polyps, then they're probably not within this group and will probably need a referral. So this is what it means. If how you treat them. For the viral wheezers, just intermittent bronchodilator is fine. For suspected asthma, you treat them with inhaled steroids. The other nuance here is that we'd like, the suggestion from the national guidance is that you treat them only for 2 months and then stop the treatment and see how they do, only to restart the treatment if the symptoms came up again. So start, stop, and restart, and do the basics of asthma, which we would do for all other children or adults for asthma. To go with it, we've got plans which we are happy to share, and I will get to where we host these plans and things, but we're essentially a similar plan to Asthma Lung UK for older children, but mainly based for wheezing. The reason to do start, stop, restart is because it's a balance, really. Inhaled steroids. We know that steroids, they don't let your lungs develop in the way they should. We know that women, when they get antenatal steroids, when they're threatened with preterm birth, those lungs are never normal. So the lung development is never normal. And we know that leads to alveolar simplification. So we have to be a bit careful about using inhaled steroids in developing lungs. There is also a concern about adrenals and the concern about height. Now, and that people do ask me this question: what is the impact on height? And the answer to that is, if you were to take inhaled steroids daily for 2 years, that knocks off 1 centimeter of your adult height. So if you are from a tall family, that 1 centimeter probably does not matter. But if you're from a short family like me, every centimeter does matter. Okay. We know, and I hope I've shared enough information to say that it does reduce symptoms, it does reduce the exacerbations. What we are not sure of as a community is that whether, the first picture I showed you where lung functions decline in a proportion of asthma patients, we're not sure whether it stops the lung function decline. The general consensus is that if you keep them well, they will grow well, and if there is less twitching of the breathing tubes, hopefully they don't develop a fixed obstruction later in life. But if you ask me if there's a strong evidence, probably not. So it is a balance, and that's why start, stop, restart. This is just to summarize, but also just to mention that the reason I've said 2 to 5 and not under 1 is because the commonest cause of wheezing under 1 is bronchiolitis, and nothing works for bronchiolitis. Pediatricians have learned it the hard way. Nothing works for bronchiolitis apart from supportive care. If they're not feeding, if the saturations are low, you give them oxygen. So this is essentially 2 and above. Okay, enough has been talked about this today, and hopefully I can convince that it's not a good idea in children as well. This is a study looking at how much SABA was being prescribed to children in various age groups: 1 to 5, 6 to 11, and 12 to 17. As the number of SABA canisters increases, the rate of exacerbation keeps on increasing. So the same thing which was true for older children, which Arti and Debs kindly pointed out, is true for younger children as well. And so SABA, not great. What are we doing? And this is very much in the hospital, and I'm taking credit, but these are Deb's work. So we are actually trying to stop children going home with a prescriptive weaning plan. So if you remember, we used to send them and say, can you take 6 puffs every 4 hours for 24 hours? Then 4 puffs every 24 hours for the next few hours, next day. So we were giving a lot more salbutamol, and it was giving the wrong message. So we've aligned that message, and now we're going to be sending children home with as required salbutamol. So they would start with 2 puffs, go up to 4, 6, 8, 10 is the absolute maximum they're allowed at home, and Debs has worked really hard to produce these things. These are very much secondary care, but if you wanted to have a look at them, we're happy to share. This is the advice we're giving to children as they're going home with following an asthma attack now. So we're moving away from a regimental reduce inhalers this way to as required and slowly building it up. Now, I think we talked about GINA, but this is the old guideline, isn't it? That's how you go up but GINA has changed, and this was a big paradigm shift in terms of using. I'm not going to go over it again because, Deborah, you've covered it very well. I'm just going to say, where is the evidence in children for this sort of thing, even for adolescents? So the SIGMA studies which you referred to, which compared regular inhaled steroids versus using budesonide formoterol combination, in the whole of those studies, there were around 1,000 adolescents. And the numbers weren't a lot, but the signal was the same as adults. So the exacerbations as compared are similar as compared to using budesonide all the time. So I think we feel fairly confident that above 12, maybe this is the right thing, but there has been more evidence which I've not presented. But just to say that within those SIGMA studies, the novel start and the practical studies, which are the other big studies, did not have children. So we're basing that recommendation on around 1,000 children across the country. But there has been other evidence. This is a study where they used similar sort of a similar sort of strategy, but the children had to carry around a lot different inhalers because they don't come as one. And the worst exacerbation stays when they're using salbutamol alone. And between the dotted red line and the solid red line are children who are using either budesonide all the time or using budesonide salbutamol as rescue. So even in younger children, we are seeing the signals, we are seeing the evidence that actually using an anti-inflammatory for rescue may be the right thing to do. And this is another big study which came out of I forget now, but again, children right from 4 years onwards to adults, 3,000 plus, and they had two different strengths of the reliever inhaled steroid combination to be used when the symptoms went up. Again, sort of reinforcing the point that if you use anti-inflammatories for rescue, you're probably doing at least as well as using as well as using budesonide all the time. So I think there is emerging evidence, not a lot of it, but enough to throw our weight behind it. Now, I want people in this room to get very cross with me. And that is because, having said that, it's adherence really. You take it well. Both my colleagues have already reinforced that. Nowhere is it more true in children because they're carrying these spaces around. Said at children's we're starting to introduce dry powders around 10 years, 11 years of age, so that then we can prepare them to go into. But we have also heard of horror stories about their inhalers being changed on text. I hope that doesn't happen anymore. If we are changing them to dry powders, we need to make sure that they are taking it well. That brings me to the second bit. This is very small, and I don't expect you to read all of it. I'm just going to take a little break. And this is the BTS and NICE guidelines. And I'm just going to outline what the main differences were. So BTS said, take a history, see if asthma is probable, treat them, and if they get better, they have asthma. If you're not sure, then you do some objective tests and then clarify your diagnosis. Whereas NICE made it mandatory to, after you've heard the symptoms, to do objective testing and then go on to treat the child. So that was the main difference between NICE. And NICE has been there since 2016. So NICE is saying symptoms, test for airway obstruction and inflammation, and this is the sequence in which they want you to do the test. They want you to do spirometry and reversibility first. If somebody has clear reversibility, they have asthma, you'd code them asthma. If this is normal, and quite often in children, spirometry is normal, then you go and check FeNO. If FeNO is above 35, you can again code them as asthma. If FeNO is below 35, then you ask them to do peak flow recording and see for variability in peak flow. I've been asked this question about, can we do spirometry in children? We can do spirometry 4 years and above, just needs the patience, and we do it. And there are reference equations to do it. The FEV1 to FVC value, now that I think the mantra is 70% to diagnose obstruction, but children come in all shapes and sizes, and the reference equations will now give you a lower limit of normal to look at. And actually 70% for children will look some children will look really bad in terms of obstruction. Peak flow is available to all of us, and the problem we know about peak flow is that people make it up. They write it in their diaries as they're walking to see you, and you can see it's all in the same pen. Maybe I'm just very cynical. Maybe they do it. But there are some technological answers to that. This is the digital digital health passport app, which we are endorsing as a part of the asthma program. And really good app. It will give you, allow them to record their peak flows, but give them a lot of other information they would need. And children like apps these days. This is the new kid on the block, FeNO, and some of the PCNs have FeNO, and I think some of it is creep. what I'd like to say is that there's lots of false positives and negatives. If you're using pheno, just be aware there are lots of false positives and negatives to pheno. None of the guidelines at the moment suggest using pheno by itself, but if you're using it with a good history and you're seeing high pheno, then probably the child has asthma. It's easier to rule in asthma than to rule out asthma with pheno. But if I stick to the guidelines, none of them allow you to use pheno by itself. There is very variable evidence about. Some people say that if you use it in every clinic, you'll cut down the amount of inhaled steroids. Actually, I see the contrary is true, and big studies have not shown a change at all. My own practice at the Children's is we do not use pheno routinely. We use it in only our complex asthma clinic, or sometimes if we get a fresh referral from you who is steroid naive, then we will probably use it. That brings me to diagnostics, which is the hard question. And I'm hoping that some of you in this room are commissioners or have some leadership roles and I can engage with you. Because I could have left this slide empty, really, because there aren't any diagnostics of children unless some people may feel confident enough to do it in adolescence. Is it just the test? Do you just need a number? Or is it actually test plus your expertise there which matters? Where should these happen to? Should these happen in primary care? Should these happen in hospital? Should these happen in specialized diagnostic hubs? A lot of regions around the country have included them in their adult diagnostics, and I may be a little bit. I understand that we don't even have adult diagnostics set up to any great level here, so it's a bit difficult. But there is these home-based diagnostics who will onboard you onto the home peak flow meter, and you can record that for a period of time, which can help. Am I doing all right for time? So I was hoping. I am very much an objective person, but I have to be a bit pragmatic and say it is a clinical diagnosis for the moment. For anybody else, you could refer over. If you're using treatment and you're going just by symptoms, if it's a single symptom, if it's breathlessness alone, please don't give them a SABA. It's probably because they're overweight or never exercised. If it's only cough, and if it's a wet cough, yes, we need to see them for something else. But if it's a dry cough, it's probably post-viral or maybe an evidence of some allergy. So if it's a single symptom you're treating with asthma treatments or inhalers, then please do stop and see have things got better and restart it or consider a referral. We anecdotally, we've received a lot of referrals which say, can we have spirometry and pheno? We are not quite set up, at least in Sheffield, to just provide that service. We take it as a clinical referral and we will see, which means that we are getting a little bit overwhelmed, but that's okay. That brings me to the last bit of my talk, and what I have here is within asthma word, there's been an increasing recognition of the part the environment plays in asthma. So asthma doesn't occur in a silo. Damp and mold has had some really bad press. You know the tragic cases where children have died. Air pollution, the coroner in London recognizing air pollution in that child's death certificate. So there's a lot of recognition that asthma does not occur in silos, and triggers has been one big thing nationally that we have tried to reinforce and ask people to think about triggers, ask about triggers. Which brings me to, I think, Arti, you mentioned that whatever we do for asthma, we need a system-wide approach there, isn't it? We not only need to get the influences around deprivation, around pollution, around smoking cessation right. When they touch A&E, when they come in via the ambulance, they should receive that steroid within the hour. They should get their asthma review, and so the whole system needs to work together, and that has been recognized, and we've been running this national program trying to deliver a bundle of care which recognizes each of these elements. My co-lead is Deborah on this program, and we are trying to chip away at it and make small changes everywhere. We linked into housing all across all areas in in the ICB, and we've got good links to be able to signpost children into, to be able to, if they're in private housing, we know where we can get them help. Similarly, good links with smoking cessation, so looking at that environment side, looking at what's happening to them in school. And we're trying to chip our way through the guidelines, trying to get those guidelines so that they say the same thing, whether you're in Barnsley, whether you're in Sheffield, whether you're in primary care, or whether you're in secondary care. Ambulance service, work in progress. And again, on the severe side of things, and that's underpinned by training, and that's underpinned by data. The national metric at the moment which is being used is asthma admissions, and regretfully we do have a very high number of asthma admissions in our area. I'll encourage you. You can use the QR code to go to this website. The Healthier Together website contains a lot of information about children, but we have our own asthma page there, which talks about all the things around. If you needed to send somebody to, get them help with housing, it'll give you information if they're in a private rented accommodation. It'll give you information if they're in social accommodation. It'll give you VCSCs you can go to. It'll tell you where your nearest quit smoking service would be. There's some amazing resources prepared by my colleagues in the Moving On Asthma team, very directed at adolescents, in their language about how, and please do signpost them to there. We've got information about inhaler technique. We've got so it's a one-stop shop, and it's our repository of all the things you might need to look after children and young people with asthma. This is a little bit of an ask. To be able to care for children effectively, children with asthma effectively, we want every person who looks after children with asthma to be trained to the right standard. And this starts with school teachers and football coaches having awareness of asthma at Tier 1. For the vast majority of you looking after children with asthma, you'd be in Tier 3. It is an online training which is freely available, but yes, training is free, but your time isn't. I'll strongly encourage you to please take up this offer, especially if you're seeing children with asthma with some regularity. So that's the Tier 4 and Tier 5 I haven't put on are very much related to secondary care.
Is that on e-learning for health?
E-learning for health, that's true. And again, if there's any problems at all, please do get in touch with us. This is a part of what we're doing, which I'm really proud of. We've engaged with schools all across the regions to accredit them as asthma friendly. And what that means is that schools have a policy about how they manage children with asthma. And as Deborah Nati has previously mentioned, we're changing the paradigm, we're changing the ethos here that symptoms are not acceptable. So it is no longer acceptable to ask your PE teacher for your inhaler if your asthma is controlled. So we've gone away from giving children asthma plans in school. Schools have a single emergency plan and emergency inhalers if they need to. What we've said is that if the PE teacher is noticing that children are coughing more, they should be able to communicate it to the parent. And in some places like Doncaster, they've got good links with school nurses as well, so they can pick up when the teachers are recognizing that children have poorly controlled asthma. So we are changing the expectation here to no symptoms at all. The other ask of schools is training, and over 1,500 teachers in this area have already trained up in Tier 1. So we've got a lot of buy-in there. 80 schools in various stages of certifying as asthma friendly, and I need your support to get more and more children, to keep them safe in school, to get the message about good asthma care right where it matters. That's what I have to say. I'm happy to take any questions, and there's some QR codes for you if you didn't manage to get them the first time around. And those are my key messages regarding asthma. Thank you for listening.